كل عام وانتم بخير. عيد مبارك everyone. It's been a great holiday, I hope, for everybody. For NASAM, we really appreciate everybody's work during the summer on this project. It's been very good progress, actually. And I think it's time now to keep moving with this project forward to get the full benefit out of it. So we are looking for some really good presentations today. We have an update from Seaman Qasim. We're going to present update on the project we're progressing and what we would like things to be done. Then we're going to hear about spontaneous breeding trial by Mr. Faisal Basir. And then we're going to have experience sharing from Mr. Ali Hassan from Najran, who are going to tell us about their experience about NASAM in their hospital. We have heard many great stories from many sites, and we like in different meetings to share them. So it will be fantastic. So we'll start with Iman giving update on the NASAM progress.
Hello everyone, I hope you can hear me. NASAM bundle data entry per month. Actually, we have a little bit of progress, and I would like to share that with you. As you can see that the line is moving up in July, so hopefully in August we will find the data is moved more progressed better, and the data entry is completed. Also here, as you can see from this report we've been sending you, it's much better. The progress green line is showing in multiple places, and less red. Hopefully will continue like that, and data entry will be much progressive. This is for only NASAM bundle. Hopefully other variables like the early mobility, also we need to work on early mobility. It's a little fewer because it's not mandatory, but still we prefer that you enter data for early mobility, as it's very important for mechanically ventilated patients. For VAE data, we really, as you can see from January, I know that most sites has just started on VAE, and we would like to remind you, either you can have the VAE data from the VAE form that we provided, or from the infection control if possible, if they're doing it, but it has to be following the CDC definition and the format, similar at least if it's not the same. And please, at the end of each month, scan all forms and send them to email nasam@ngha.med.sa or nasam.ngha@gmail.com. So I would like to ask, yes, sure.
We have 15. 15 people log in, maybe one of them is us. So no, these are outside. So we have 15 also. So a couple of comments on this. I really again thank everybody. I just want to put the slide of Iman back here, so you could see more sites becoming completing data, so becoming green. And this is given that it was a summer holiday. It's actually great. I mean, many sites really push forward. But I think it's now time. Now we're September, so everybody should be back to work. I think we should be optimistic of making all green, right? And I think I think this is the fact that we were able to do it during the summer proved that it's doable in everywhere. So I think we really need to push forward. The VE, as Iman mentioned, it's a critical part of the project. So we need the VE completed. As Iman said, if you have it from, you're going to use our forms, perfect. If you don't want to use our form and you want to use infection control data, it's okay, but you have to do it consistently using infection control. You cannot flip back and forth. So throughout, you have to do it one way. And the outcome measures also, the outcome measures which you didn't show, we really need this data as soon as possible. Enter. So this is fantastic. Dr. Zuhair Asiri, want to make a few comments?
Thank you very much, Prof. Yassin and the crews for this very nice initiative and project and the follow-up for our progress in municipal hospitals and others. Few updates. Number one, we had a meeting between us, Minister of Health and Infection Control, Minister of Health, and National Guard personnel as well, specifically the NASAM group, to change the VAB form to VAE form. So I would like to encourage all Minister of Health hospital to use the National Guard VAE form from now on. There will be a clear direction from the Infection Control and Ministry of Health because we are in the final stage to adopt the VA form from National Guard, which is good. Where's the camera? Where's the camera, Iman? Only sound? Okay. It's very important that we start using the VA form and all Ministry of Health hospitals, plus other centers as well. If there's any issues or any problem with the VA form, please share it with us in the group, especially for those representing NASAM in their hospital. I'm very happy and glad that about the progression of the entering the data and the system, and hoping to see more adherence to data entry in the next few months. As Prof said, if we did it very well in summer, we have to do it way better than during the working days and hours. Again, if there's any questions, any comment, any concerns, we are open. You have my mobile phone, especially for those Ministry of Health hospital personnel, and the NASAM group as well. And thank you very much. Mic to Iman. Faisal. Here.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, ladies and gentlemen. I'm Faisal Al-Basit, respiratory therapist from National Guard Hospital. And today, inshallah, I will explain the spontaneous breathing trial and when we should conduct it. So, as the introduction, the SBT trial, which is trial performed on mechanical ventilated patient inside the ICU to assess their ability and their effort to breathe by themselves while they are receiving minimal mechanically ventilated support. So after I explained the SBT trial, now we need to know what is the relation between the SAT, which is spontaneous awakening trial, and spontaneous breathing trial. So I will start with the protocol actually. We go brief. Each protocol is contained of two processes that include safety screening, which is spontaneous awakening trial, and trial period, which is the SBT. If we combine the SAT, the wake up and breathe protocol, using them together to achieve better patient outcomes. If the patient fails at any time to the safety screening, the trial is not initiated at that day.
Could you please mute yourself, everyone?
So again, to repeat this slide, if we combine the SBT and SAT, it will end up with wake up and breathe protocol. Okay, if the patient failed at any time during the safety screening, and then we will not proceed for the SBT trial. So the following chart illustrates one example of the spontaneous awakening trial, and I will explain it later on, inshallah. And we should do it daily, every 24 hours for the patient inside the ICUs. And again, if at any time the patient fails during the screening, then we will not initiate the SBT. So this chart, of the example, we need to screen the patient every 24 hours. So I will start with the SAT safety screening. If the patient with no signs of active seizing, alcohol withdrawal, not agitated, not on balance agent, with normal ICP pressure, no myocardial ischemia, and then we will proceed for the SAT screening. If the patient failed, patient become agitated, respiratory distress, tachypneic, then we'll put him back again, but half of the dose of sedation. For example, if the patient on fentanyl of 50, then we'll make him on 25. So let's assume that the patient is successfully passed the screening, the SAT, then we will go to screen him through the SBT safety, okay, which is pressure support, for example, 5 or 8 with minimum of I2. So the patient not agitated, not desaturated, doing fine, with minimal effort, then we will perform the SBT. If the patient failed at this point, we will put him back on mechanical assistant again with control mode. If the patient passed again, we will consider the extubation. This is our protocol from the hospital. You can use it or you can conduct your own protocol. Daily, we are assessing the patient either on the tracheal tube or tracheostomy. If the patient meets this criteria, first one, if I2 is than 40% plus the B less than 8. So I need to evaluate the patient at this time. Is the patient maintaining fine saturation above the 88? Is the patient, for example, for 5 minutes, no respiratory effort, or this patient become agitated, then I will stop the process and then put him back again to the control mode and discuss the situation with the ICU team. If the patient passed this saturation, or this SAT process, and then we will perform the SBT, for example, pressure support 5 to 8, with the maintain the same FI2, which is less than 40%, and then I will monitor the patient for 30 minutes. If the patient passed the 30 minutes, and then I will consider the extubation. This slide actually shows to us this is an example from different units. They are using the same protocol. They have their own protocol actually with good performance. 3 examples of them. And here at the end, it's all about the teamwork. We always ensure the proper communication between the staff, RT, nurses, physician. And this teamwork requires us to educate the staff about our project, about how important the SBT daily for the patient, and in order to have a proper staff engagement and employment. Thank you very much. Any questions?
Thank you, Faisal. Can you go to the slide that shows the protocols? Great slide.
This one. It will be under the. Yes. So.
Listen, this is what I thought. This is a really nice protocol, Faisal, that combine both the spontaneous awakening trial and spontaneous breathing trial. And it's very straightforward. So it gives the first part is for the nurses screen the patient if he can stop sedation or not, and when he fails. And the second part is for the RT to see if the patient can be put on spontaneous breathing trial or not, and when he fails. Very simple. Love it. It's very nice. We have it on the website. We have this one. Well, good. And how about our protocol also?
This
is
one.
uploaded.
I'm not sure.
So can you give us to Cheryl to upload it? So we'll upload it, people can use it.
Yeah, and I
This is really nice protocol to be implemented.
yeah, thank you, Faisal. That's very good presentation. I like the screening tool, SAT and SBT, and I would like to encourage all Ministry of Health hospitals to use it. It has been done somewhere else as well, and it has been published in more than one article. It's very good in the screening tool and very safe to use at the same time. That's one comment. Thank you, Faisal. Very well done. Number two, using neuromuscular blocking agents, we have to make sure that using it in the ICU is exceptional. We should not use paralytic agent for every single patient in the mechanical ventilation in mechanical ventilations. It has been big issue. In the last few months, we have some hospitals that use more than 70% of their intubated patient, and this should not happen. The only time that we use paralytic agents is just to intubate the patient, and after that, we should not use it unless we call the ICU consultant. If there is no ICU consultant and you want to use it, that's specific for Ministry of Health hospital. You have to call the ICU on call. There is an ICU on call. You call 1937, and they will direct to the ICU on call, and they take his opinion before you start the paralytic agent as infusion. So please do not use paralytic agent as infusion unless you have you call the ICU on call consultant in Ministry of Health. And if you don't have if you don't have consultant in the ICU, if you have consultant in the ICU, then you call the ICU consultant. I think this is very important message, and we have to adhere to it. Almost 100%.
Any questions?
Questions?
Yeah, any questions? Any questions of the system? Which one is this?
Smart.
Have any questions here? Any questions from the audience? Okay, if not, I think we'll move on to the next presentation. Mr. Ali Hassan from King Khalid Hospital, Najran. Hello, Mr. Hassan.
السلام عليكم.
السلام ورحمة الله. كيف السلايدز؟
كل عام وانتم بخير. I am Ali Al Hassan from yes.
Yeah, we can hear you. Go ahead from Najran. حياك الله. I have also Dr. Zuhair Asiri here also. So I are looking forward to hear your presentation.
Yeah, this is Ali Al Hassan, Najran King Khalid Hospital. I will speak, inshallah, about our experience in applying spontaneous breathing trial.
Do you have slides?
No slides.
Okay, go ahead. Yeah, that's okay, fine.
Yeah. At the beginning, we had we spent some time in educating the staff about that and doctors to follow that. And there were some challenges like lack of staff to monitor the patient while they are on spontaneous breathing trial. And sometimes also there is a blame environment. They are blaming if anything happened to the patient while he is on not on controlled mood. And also we have family interfering if they saw their their relative on these modes, they will ask why and how, and they will give an professional suggestion. And sometimes there is a pressure to follow that without any medical opinion. And but after we insist and became more strict with
Can you clarify this issue about family? I didn't understand it fully. So what's the family interference with what?
yeah, family, they are interfering in medical decisions, and they are saying why this patient, why our relative he is uh, having work of breathing like that, and why you are not relaxing him. I mean, an unprofessional suggestion, and sometimes we have to follow. We cannot disagree.
So what you are saying
So
is some
that's
families would like their patient to be relaxed, not showing any signs of extra-respiratory work. So I think this is an important point to address, Mr. Ali.
طيب
yeah, yeah, that's
طيب علي شكرا for sharing this with us. أنا زهير عسيري in charge of the ICU in Mr. Gulf. So maybe one of the most important thing that maybe we have to do is from day one, from day zero, we discuss with the family our plan, and one of the plan that we sometimes discuss is they might see their patients waking up slowly in the ICU. So getting family as well involved from day one might decrease the chance of any argument between patients, relative, and the healthcare providers. So I would like encourage doing so with every single patient that get admitted to the ICU, being in NASAM or not in NASAM. So maybe that could help Ali in decreasing the chance of argument.
yeah, yeah. Actually, yeah. Thank you very much for that. Actually, if we insist and become more strict in our rules, and we will try also to educate the family about our rules, it will help sometimes, and sometimes not. Sometimes no, we cannot apply. Some families are not aware, and
let's go back to the communication skills. With time, احنا we have a learning curve in how we communicate with patients as well in the ICU, because 10 years ago we used to do our own business without talking to the patient relative. Nowadays, from day one, from time zero, we get family involved in our care, in the patient care, because this is their relative. So by time, Ali, I think this will the argument will decrease, and definitely our next generations will be more aware of the type of the care that we provide. Sometimes you have to tell them السلام عليكم أنا زهير عسيري أبوكم حيكون معانا بالعناية المركزة يمكن تشوفونه خلال الأيام الجاية خاصة في الصباح يكون صاحي أكثر من الأيام العادية. Sometimes you have to go down to earth to discuss things with family, and encourage their help to move things forward. طبعا not all the patients family will accept that, but majority should accept the interference. Go ahead.
yeah, that's really right. And alhamdulillah, yeah, they are improving by the time. Actually, if the patient is new, usually that's the problem. But if he became chronic already, they will start know a lot of things, and they will have better communication and cooperation to take care of their relative patient.
Right. Just let me highlight one more thing. Look how long it takes us, how long it takes Prof. Yassin to convince us and the group that we have to adhere to these bundles. A year. It's almost a year now. We are not even reaching 70%, and he's talking to healthcare providers. Just imagine yourself talking to the patient as well and patient relative. How long it will take you? It will take time, but at the end of the day, it will achieve what we want. At the end of the day, everybody will win. We will patient will have better outcome, and for us as well, we have more, better satisfactions when we have better patient outcome. Back to you, Ali.
Yeah, actually, we have also that issue because some medical staff are leaving, some new staff are coming, and some they are not really familiar with NASAM rules, and they need time to be to educated by that one and to follow this one, and they have a lot of questions, and sometimes there is time to answer all of that, and sometimes no. So still the challenge is there, and as you said, if these are the medical care providers, so what about the family, which is they are not always in the hospital, so they really takes more time to be cooperative and informed about all NASAM procedures and all ICU also procedures. Yeah, and after we insist and we became more strict in our rules, these challenges became by the time became minimized more and more. And Alhamdulillah, we are improving. We are improving in that one spontaneous breathing trial, and we had a lot of equations and discharge from the hospital. We are trying to minimize as soon as possible ICU days and ventilated days. Alhamdulillah. And regarding this,
Yeah, go ahead, go ahead.
yeah, Doctor.
تفضل تفضل.
Yeah, regarding these VAE forms, also we have some new staff, and sometimes they are not really familiar, so we have to work more, and sometimes we will repeat, we will write the form again for that and spend more time. But by the time it will improve. Alhamdulillah, it will. Yeah.
This is a great update, Mr. Ali. I think it's fantastic to see this progress. And I'm glad that you are able to manage and push this project forward. As I said, I think it's a good time now. It's September project is back, so I think we should try to refresh everybody on this project. And if there are things that are missing, let's try to catch up on it in all ICUs. I think would be very important. So thank you, Mr. Ali, for your help, and we really appreciate it.
Thank you very much, Doctor, and thank you everybody for attending that. And really, we are appreciate all your helps for this one.
Yeah. So we have a question about TRAS score. We have a patient about TRAS score. What do you put TRAS score if the patient is not sedated? What do we agree on? So I think we should make a clear rule and put it on the group. This is for sedated and non-sedated patients. For sedated and non-sedated patients, so you approximate. I think if the patient is agitated, you give him agitation score. If he's not agitated, you give him the less scores. So our using for sedated and non-sedated patients. Sorry. About TRAS score, what do you put TRAS if the patient is not sedated? If he's awake, you give him, and not agitated, you give him, what does he get? Zero. Zero. If he's awake, calm, not agitated. Yeah. Because it's a sedation and agitation score. It's not only sedation. It's a sedation and agitation score. Yeah. Right, yeah, exactly. This is one of the common questions. Any other question? First one. Agitated patients contraindicated for SBT. So we have a drug addict with RTA on mechanical ventilation. Very difficult to decide which day to start SET and SBT. Excellent question. So maybe after yeah, so Faisal, any suggestion? So saying here you have a patient who is, sometimes we see some of these trauma patients really agitated, and intoxicated, drug addict, okay, agitated. And if you apply the rules, you will never meet SAT, SBT. Agitated all over. I think this is where, and these are, I think we need to remember these guidelines are guidelines, right? And they will not replace clinical judgment. We are here, and at the end, you have to make judgment. And sometimes we exhibit agitated patients. And actually, they do better when they exhibit them. So these guidelines are general guidelines. They work on majority of patients, but certainly they don't replace clinical judgment. Is that reasonable? Yeah. Yeah. So you have to use your judgment. And أحيانا we've seen خاصة young patients, they are agitated from the tube. Some patients gag. So you remove it and actually they get better. But this is, I cannot prevent, this is somebody has to sign at the bedside. Any other questions? So as Dr. Asiri just suggested, next presentation also will have another hospital, and we like to have data. I think next time, if possible, to show the data and how they are progressing, because that's really, we want to make this project data driven, would be a better thing, right?
Can we upload the WAS and the delirium tool and that protocol in the website?
So let's. RAS is there. Present. And did we upload last time the subglottic suctioning protocol? It's uploaded. So please visit the website and see the resources there. And you have other resources you want to add, just share it to us and we'll upload them there. Yeah, the one from Kingfisher, which was great form. Also, we uploaded in the system, so anybody can use it. And our VE form is there, right? It's available, public. So we want to make this website useful to people. So any suggestions, more than welcome. Anything else? If not, I think we'll conclude here and thank everybody for attending today. And we'll see you in 2 weeks. Thank you very much.